Good afternoon or good evening. I have one disclosure, that I have no disclosures, and I have one confession. I am a transplanter, which is not easy to say in the public of ALL. So what do we think about, what is the traditional thinking about transplant? The way that I see it is that it is like boxing, like a combination knockout. The first one is the jab, that is the cytotoxic element that, of boxing, and the second element is the cross-cut. This is really what knocks you out, and so this is the first one. And the second one is the graft versus leukemia effect. I will focus my brief talk about the jab because the graft versus leukemia is what we focused most of the last 3 days, and what is mostly what is to come, what is yet to come, and what we will hear shortly from Steve. So there are a few questions about the jab portion. What is the optimal source? This is our traditional view, and so is there, a patient was diagnosed, is there indication to HCT? If no, are there any other therapies available? And if yes, this would be the hierarchy of the decision. Is there a sibling available? If not, is there a match-unrelated donor available? Is there a cord available? And most recently, is a haplo available? So a lot of this tree is based on the history of bone marrow transplant. In the 1950s, the first reported syngeneic transplant using TBI. In the 60s, better understanding of tissue typing, the introduction of allogeneic sibling towards the end of the 60s. In the 70s, improved supportive care, introduction of non-TBI preparative regimen, further improvement in outcome. In the 80s, vast experience from the Chernobyl disaster led to even further understanding of the mechanism of hematopoietic cell transplantation, and better definition of the indications. And around that time, the introduction of the ability to mobilize hematopoietic peripheral blood stem cell transplantation with chemotherapy and later with GCSF, growth of number of hematopoietic stem cell transplantation. In the 90s, we had the introduction of haploidentical transplant through the work of Yair Reisner and the Perugia group using megadoses of CD34 and T-cell depletion, which was the real big opening door for the use of haploidentical transplant in treatment. At the same time, about the same time, Gluckman at first in France and later across the globe, explosion of the use of cord blood donors for the purpose of hematopoietic stem cell transplantation, initially in children, and later with the work of the Minnesota group, led by John Wagner, the use of double cord transplant. In the 2000, kind of mid-2000, 2005, 2006, the introduction of the Johns Hopkins approach of haplo. This is the sequence of events that I showed just a few minutes ago, and this is reflected by a slide that I believe we have seen this last 3 days. These are the bone marrow transplant. This is the curve of the increase in the use of bone marrow transplant. Here's the introduction of a peripheral stem cell, increase of peripheral stem cell. Around here is the introduction of cord blood, and what we see a gradual decrease in the use of bone marrow, gradual increase in alternative sources, and probably in 2014 we will have here another color, and quite possibly a change in the colors of the other columns as haploidentical transplant start to take their place. This is where we are. And this is a graph taken from Mary Eapen work a few years ago in 2007. When she looked at all sources, here an outlier is in children, 6 of 6 related cord blood appear to have a superior outcome, but the number of transplant was quite low. All other sources actually kind of merge pretty much as what we have seen in the last few slides this afternoon. In another work from the CIBMTR, that is from 2012, comparing different sources of transplant, of grafts. Yeah, there is increased transplant-related mortality there, with metron-related donor. There is a decrease in relapse-related mortality with the alternative donor. But when we look at the, sorry, I missed that slide, but when we look at the total outcome was quite comparable between all the sources. A work by the European group, Italian-French group, looked at the same things, and they found similar findings. Acute GVHD was much more with mismatch related, for some reason with sibling, less with haplo, but chronic GVHD was more with siblings, less with haplos. Overall, what matters is that when you look at transplant-related mortality, again, more with the cord blood and with the metron-related donor, but when you look at the outcome, the survival, everything merged pretty much towards the same point, which is about 42 to 45%. With the exception of cord blood, but even that was not statistically different. So this is the previous graph. By mistake, I misplaced it. So this is what we are looking at today. A few people here spoke about the issue or the value of the getting to the transplant in a timely manner, because quite often we could have identified a donor for the right patient, but we wait too long to find the ideal donor. Siblings is not available. We are waiting too long for a metron-related donor. I believe that the current scheme is something that would look like that. Is there indication to transplant? If no, are there any other indication? If yes, is there a sibling available? But if not, and this answer should be known quite fast, we would move to whatever is available at the shortest period of time, because the outcome appeared to be quite similar. Let's talk a few words about the intensity of the intensity required to the treatment. So this is a classical graph presented several times in different places. This is the range from non-myeloablative to myeloablative, the range from mildly toxic to highly toxic, and then the expected value of graft versus tumor. You know, that kind of, the least intensity, the more graft versus tumor you need to get the same effect. The more toxic you are, you probably will overcome some of the issues of you will need less graft versus tumor. That is a classical thinking. So one question that Ralph answered earlier, TBI or not TBI, plenty of studies. One classical study was presented earlier. This is a study, a graph that we just saw, where really the non-TBI containing regimen fared quite poorly compared to the TBI. So here the answer is simple. A more recent study, again by the CIBMTR, looked at 4 groups, a different combination of Cytoxan different combination of total body radiation going from the least toxic to the more toxic, and try to see would there be a difference. And you can see there that really, almost regardless of the toxicity of the regimen, the outcome was the same. Probably because you may have gotten less relapse with the more toxic regimen, but you surely bought more toxicity. And so that is kind of the equation that we are standing. So the conclusion of that study was that there was really no difference between the different variation of total body radiation. The outcome was the same. So now we really come to the jab, the crosscut, the knockout. I would not be the first one to say it during this meeting, but we clearly are in the beginning of a new era. I think that the conclusion from what we have said so far is that we are probably getting to a point where we may not need all the toxicity that we are getting now with heavy total body irradiation or heavy Cytoxan, because the methodology of stem cell transplantation, what bone marrow transplantation is just the primordial adoptive cell therapy for what is to come in the future. So part of it we heard today from an excellent presentation by Dr. Grapp about TCAR cell therapy. It probably will include a lot of other immune modulation, including monoclonal antibody, BITE. We heard somebody mentioned BIKE the other day, maybe by natural killer conjugate regimen. So we now have a different and competing option for alternative donors for patients who lack an HLA identical sibling. So we are not bound to one system, as indicated by Ralph in his talk. The outcome appears to be comparable using either MAD cord or haplographs when correcting for disease phase and diagnosis. The time to identify a suitable donor remains a crucial issue. Therefore, when it's indicated, move forward with the best available donor. The cost of each procedure, including donor search and stem cell procurement, is an additional issue. With the available donor sources, theoretically, some of the cost of procuring a donor may be coming down with the competing options. And with the increased importance of the crosscut, not all jabs have to be myeloablative. And I really think that this is a key to justifying to understand the role of the future of bone marrow transplantation treating ALL. Thank you. I want to thank my colleagues. I see Julie Wilson there, and our nurses, and of course, more than anybody else, our patients who are the inspiration of all that. Thank you.